Good afternoon, everybody. For those of you who don't know me, I'm Mike Klag. I'm the dean of the school, and for a short time. And I want to welcome everybody, alumni, staff, friends, faculty, to today's presentation. So, as you know, this Alumni Day was a tradition we had, and we let lapse, and maybe 6 or 8 years ago we restarted. And it's a special day for all of us to get to see people who come back to the school, who we know and remember and have a chance to talk. So we just had a ceremony for folks who were awarded university alumni prizes. So these are recognitions that are made by the university, not by our school, but sort of in competition with other schools. And I think we had 56 awards this year in our school. There are 10 divisions in Hopkins. Our school got 14, which says something about what our alumni do. Now, there was one person who won an award who wasn't in the audience at the time, and it's Donald Michael Steinwachs, right? And so
do I have to stand up?
you have to stand. And So I told Don that you all gave him a standing ovation there, and I just wanted to recognize you. So thank you. So we're scheduled to have a conversation this afternoon, and originally we had asked Shelley Hearn, who is the Director of Trust for America's Health, to be here, and unfortunately there was a family emergency last night, and she had to cancel. But we have a very exciting person in Shelley's stead, and I'll tell you a little bit about our special guest in a minute. The purpose of this, what we're going to do this afternoon, is really both to talk to each other, the guest and I, and to talk to you. So, and our guest is Michel Sidibé. He is the Executive Director of UNAIDS. He is here today because he worked with Ruben Del Prado, and Ruben had invited him as a guest, and we imposed on him last evening whether he would sit in, and he agreed to do it. So let me tell you a little bit about him. As I said, he's the Executive Director of the Joint United Nations Program on HIV/AIDS, UNAIDS, and he is the Under Secretary General of the UN. He's a long-standing champion of people-centered approaches to health and a strong advocate for social justice. His commitment to advancing global health began in his native Mali, and later at the UN Children's Fund in the Democratic Republic of Congo. After working there in 2009, he was appointed the second Executive Director of UNAIDS, and he's had an incredible impact on HIV and AIDS worldwide. His mantra, his vision of zero new infections, zero discrimination, and zero AIDS-related deaths has been a clarion call to the global health community and has driven incredible progress in our response to HIV. Under his leadership of UNAIDS, more and more countries have set measurable targets to end the AIDS epidemic as a public health threat by 2030. His idea of shared responsibility and global solidarity has been embraced by the international community and has earned him widespread recognition as a passionate champion for health and humanity. He was named as one of the 50 most influential Africans by the Africa Report and one of 50 personalities of the year by the French newspaper Le Monde. He's won numerous other awards, including honorary degrees. And if I spend time doing that, we won't get to our talk. But needless to say, he is a world leader in HIV treatment, prevention, global health, and global diplomacy, soft diplomacy. So please join me in welcoming Michel Sidibé to the stage. Why don't you sit there? So we had our first chance to meet was today, and in a short conversation, I was immediately impressed that I'm not going to have to do anything here, so it's going to be an easy pass. But you have had an incredible career, and we didn't go through all of it. But raised in Mali, your mother was from France, your father was from Mali, and you've risen to be an incredible advocate, but also not just a visionary, but a manager, right? So we wanted to, there's some students in the room and some people who are early in their careers. What's the secret of your success in terms of being successful in getting people to work together and in getting them to share your vision?
Thank you very much, Mike. I want just to say thanks to Ruben, because Ruben Del Prado is certainly one of my best staff, working in the field in different places and trying to echo my vision, a vision of zero discrimination, because that is central to whatever lead me to be what I am today. I want to say that you will never be a transformative leader if you don't believe on social justice, if you're not capable to put yourself in the place of people who are left behind, people who have been excluded. And from the beginning, I was saying to the student this morning, it's important to dream, to have a dream, to be able to follow your own dream. But at the same time, you need to understand that you're a privilege to be in school like John Hopkins Public Health School or any big school. You're a privilege. And this privilege needs to help you to be close to those people who are excluded. So inclusiveness is key for me. Respect of dignity is key for me. Making sure that we never forget those people who don't have. And remember that we are in the right side of the road. Mm-hmm. And making sure that we build bridge with those people will lead you to a different part of the world, mm-hmm. and will bring your advocacy in different way. Now, it's important to just be passionate about what you're doing and having also compassion, mm-hmm. but it's not enough. Mm-hmm. What you need is to transform this passion and compassion into a result, mm-hmm. and that means thinking about setting goals. Mm-hmm. But when I said set goal, you have to be ambitious. Again, don't set goals which could be met by anyone else. Mm-hmm. Have a big dream. When you said zero discrimination, we know that we will not get zero discrimination tomorrow morning. Mm-hmm. But when I was sitting with Isaac, when Isaac told me, Sidibé, one of the biggest problems I was seeing already long time back is that people were thinking that being gay is just Western issue. Mm-hmm. It's not true. Mm-hmm. Being gay, injecting drugs, having sex work exists every single place. Mm-hmm. So not have the courage to say that we need to reach those people who are excluded to transform our response, you will not be able to achieve. So goals, mm-hmm. result areas for people who are left behind is critical to drive change.
So I hear you, the big vision, right? Altruism, care for everyone, and set ambitious goals. But one of the things I've been impressed with about your leadership of UNAIDS is that you set ambitious goals, but they're easy to understand and they're catchy, right? So 90, 90, 90, 0, 0, 0.
Yeah.
So
fantastic,
right?
Yes. No,
it's not hard to remember those goals. Right? Yeah.
Yes, my father used to tell me, any vision which is not passing the test of a taxi driver mm-hmm. Will not be implemented. Mm-hmm. It's not anymore a vision. Yeah. It's a book. It's probably a big strategy, mm-hmm. but it's not a vision. Mm-hmm. So for me, I was always saying to myself, the day I will have a chance to lead, I will always pick a vision mm-hmm. which could be translated mm-hmm. into reality for common people. Mm-hmm. And 000 is very simple. Anyone can understand. No one wants to have his daughter born with HIV. So I want zero baby born with HIV. So they will fight for making that mm-hmm. zero possible. Mm-hmm. I don't say it will happen tomorrow. When I said no baby should be born with HIV and we should keep the mother alive, people were laughing. Mm-hmm. But today we have countries after countries are demonstrating that is possible. Mm-hmm. And it was based on the data, evidence. You always need to work from evidence, from science to build your vision. You should not build it on vacuum. So, we realized that the developed world were already eliminating the transmission from mother to child. When in Africa, we're still having 400,000 babies born with HIV. Babies were dying because they could not get access to treatment. So I said, 0 babies born with HIV, and let us keep. And today, South Africa, 70,000 babies were born with HIV just 5 years ago. Now they have less than 3,000 babies. So it's possible. Let us make clear the goals. Let us drive a policy reform and the programmatic action close to people, close to people, close to people. Because if you miss a community-based approach, you will not sustain any gain. You will have to do it again and do it again and do it again.
So let me return to your statement about goals should be simple and clearly understood. Let's talk about the Sustainable Development Goals. Right?
Yes.
And they're not simple, right? And they're complex, and they have 169 targets or whatever it is. But your charge, part of your professional responsibility, is to implement those, right?
Yeah.
And what challenges does that create for you? Do you agree with me that they're not simple? Right?
No, I fully agree with you. What we are trying to really say to the world after the Millennium Development Goals, they were clear. We were knowing what to achieve. We realized that the biggest problem we were missing completely this cross-fertilization. We were not capable to really see the health, for example, the determinant of good health as a problem of gender inequality, as a problem of unemployment, as a problem I heard today, climate and health, as a problem of security and health. So this Millennium Development Goal is to say, okay, let us not lose our capacity to be result-oriented, focus on critical issues, but let us broaden our response to understand that if we don't have this cross-fertilization, it will not be sustainable. We saw that how we will make our health system responsive. If you look at what is happening today in many countries, and I want to take this example, Sierra Leone. I visited Sierra Leone. I met all the civil society, people working in the ground, and then the president, and they were celebrating 14% economic growth sustained for 10 years. It took them 1 year of Ebola to have a negative growth. So it means that we have a major problem. It's not just producing a growth and not redistributing this growth, and growth without quality will not be able to change. So for me, SDGs is complex, but is up to us to really make sure that it's working for society. Pick our goals, make sure that these goals, we don't respond. For example, HIV/AIDS. I'm responsible for HIV/AIDS in the world, but I was the first leader to say, let us take AIDS out of isolation. If we keep AIDS in the corner, we will never be able to see the integration with TB, with cervical cancer, with reproductive health, with maternal health, with child health. So when I was there, I said, yes, exceptionalism is fine, but we need to see little bit how we bring all those things together. And that's why I'm pushing now more and more to think about community health worker, to think about delivery system, which could be making us closer to people to sustain our gain. If not, we are seeing already the limit. You know, when I joined UNAIDS, we were struggling. And Isaac was reminding me that we could not even give a treatment to people. But today we moved from despair to hope. We were not having 50,000 people on treatment in Africa, 15,000. And that is not 100 years ago. I'm talking about 15 years back. We didn't manage to give 50,000 people treatment. Today, we're talking about 19 million people on treatment, 19.5 million people on treatment globally. We have more people for the first time in the history of this fight, more people on treatment than people waiting for treatment. So we managed to reduce mortality rate by 50%. We are seeing, like I said, countries after countries announcing that they don't have babies born. We can win, but we are not there. To be there, we need integration. We need to demonstrate that our system can take, and we need also sustainability. You talk about it, and it's very important. How we will sustain? It's not possible to ask to the taxpayer of US to be the only one to pay. I have to be honest. Their compassion, their contribution have been helping us to do a lot. We need to continue to have their support, but we need to share the burden. That's why I brought the concept of shared responsibility and went to the president, African president, and have a roadmap in African Union. And today we are seeing also for the first time in a disease response, we have HIV/AIDS. We have 57% of resources, total resources coming from domestic. We shift from 85, 90% to coming from external fund to today 57% are domestic resources. That is important. Countries like South Africa were completely in denial. Today they have denial. Today, they have almost $2 billion coming from their own budget, and they have the biggest treatment program in the world. So we are trying to change that.
So you mentioned in your answer Ebola and the effect on the economy. So Ebola also taught us that global health response is not as optimal as it should be, and there are problems with coordination. There's a lot of talk now about WHO and how WHO should be organized and how do we improve our response to not only epidemics but to a whole host of things. You're an insider, right? What do you think? What should we be thinking about doing with WHO as we move forward to make it a more effective organization?
Now I will be very diplomatic. We have my brother Tedros, who is from Ethiopia, leading WHO, and I'm sure he will do all he can to transform WHO. But WHO need a profound reform. WHO need to be able to bring a vision which will help to make sure that we are responding to the emerging potential epidemic in different way. WHO need to be, from my point of view, capable to move from 50 years back to a world which is completely globalized and define their positioning in function of that. So, and also we know that WHO need also to think about their regional offices and the interface with the headquarters, how they work together, how they will be able to respond quickly, how they will reduce the bureaucracy. So many things which are there, which need to be addressed. And I think Tedros is well placed. He's coming from the field. He was a medical doctor working in decentralized level and minister. So I hope with the support of
Minister of Health, but also a Minister of Foreign Affairs.
And also is a failure of member states. I have to be honest. It's not just a WHO. It's a failure of member states because we have not been enough responsive to really make global health a central piece of the world economic security reform. So, and health has been taken just in the corner, like if we deal with disease. And for me, health is something more important. That's why we need a global health diplomacy. That's why we need to use health as an entry point like AIDS did to bring civil society to not be too much state-centric. We are too much state-centric when we talk about, unfortunately, health, instead bringing civil society, private sector, innovation. That's what we did. We learned that from HIV, and also moving from disease to people-centered. Honestly, unless you talk about human right to health, unless you manage to think about public goods, negotiating the price of access to medicine, we were paying the medicine $15,000 per year per person. Today it is $80. We would have never reached this level of coverage if we were not reducing the price. We're giving 18 pills a day to someone who were sick with AIDS. Just a few years back, it is not 100 years, it's 15 years, 18 years. And today we are giving 1 pill a day, and soon it will be 1 injection every 4 months, 3 months. So we need to understand that this partnership with private sector, with innovators, with civil society, with different constituencies are needed. Government alone cannot do it. Your institute is working every day. They were helping me to define 1990s. So it's important to bring those bright pupils together to think and define.
So implicit in your answer is that WHO is the organization going forward to lead our efforts in global health and improving the health of people around the world. You mentioned NGOs, and so what we've seen in the last several decades is the growth of NGOs and the growth of foundations, right?
Yeah.
And with incredible amounts of resources coming from foundations.
Yeah.
How does WHO work with those foundations in the future? Who sets the agenda? You talked about the vision. WHO needs a vision, as any organization. How do we set the vision going forward for
I think
health?
I wrote a paper on that in Lancet. I personally feel that global health architecture need to be reviewed, is obsolete. I'm not scared to say that. We are too fragmented. Everyone is, and you cannot go forward by thinking that anytime you have a big disease, you need to have an organization. Organization for Ebola, organization for NCDs, organization for... So it's impossible and is unmanageable, it's too costly. And we need probably 3 main structure. One is a normative organization, which is WHO, revisited WHO, a big normative organization. But we need also a financing, global health financing organization. We cannot have, for example, Ebola crisis and having 7 billion on Global Fund or other places and say, no, we cannot touch to this money because it's AIDS, malaria, TB, when people are dying from Ebola. Whatever. For me, the ultimate goals of any public health outcome is to avoid death. Then for me, no point. That's if I have to take one indicator, that will be my indicator.
So it's the waiter saying, not my table.
Yes.
Right? Yes.
So, so you need a global health funding mechanism. But in between, what is lacking today, from my point of view, is a global health advocacy and accountability, where we can bring all the different constituencies, where we can bring all those different players together to be able to echo what is the gap in the responding to health, where information can be analyzed and shared, and where we can push with the civil society, with non-state actors to really push government to participate more to the response to health of people. You know, Mike, I told you that, or to your student this morning, you have 150 million people falling on poverty, extreme poverty every year because they have to pay their health care from their pocket. And I'm thinking about Mali, Burkina Faso, and other places. What they will do when you have almost 60% of the people in all those countries, we're talking about unstable countries today, below 25 years old. 60% of the total population. They don't have job. Their education is a problem. They don't have health care, which will, and their parents is falling completely into poverty because they have to pay for health care from their. So those don't expect them that they will be part of a stability you want to see. They will be just fueling all these terrorists and other groups.
So in a few minutes, I'm going to open it up to questions. I know people probably have some points they want to bring up. And so think about that. And we have microphones here, and we ask that you use the microphone because we're recording this. And if you don't, it won't be recorded. Okay. So 90, 90, 90, 0, 0, 0. And
3-1.
Yeah, 3-1. Yeah. So if you, well, I think, Dr. Tedros, we know very well.
Yes.
We've worked with him in Ethiopia for a long time, and he's impressive.
Yes.
And it's great to have, a director from Africa. Right?
Yeah.
Will he be able? But you talked about the problems with nations, and I think things are much better than when I started in this business. I would often go and talk to ministers of health in countries and talk about their needs when they had abysmally low vaccination rates and high rates. What do you need? And they needed more CT scanners or more MRIs. I think we are seeing more officials or ministers of health who see the health of the population as their responsibility. So will Dr. Tedros be able to unite Africa in terms of that common vision of improving health for people by working through all the determinants of health?
I think the main problem is not the Minister of Health, and I don't think most of the Minister of Health, they don't have real power on a decision on budget. So if you want really to transform health in Africa, you need to be able to mobilize Minister of Finance because of the problem we are facing today is that people feel that health is a cost. It's not an investment, it's an expenditure. So unless you bring Minister of Finance around the table and you make them understanding that investing $1 on the health of their people is a true investment, you will not. You can bring all the Minister of Health, we will agree on nice vision, but then what? So for me, the reality is to make sure that our Minister of Finance are understanding that it is a true investment, not investing. For example, Sierra Leone has one doctor for 40,000 people. One doctor for 40,000 people. How you will expect Sierra Leone to control Ebola epidemic? From where you will be able to do that? Then you don't invest there, and you're expecting to keep your 14% economic growth. Everything stop, education stop, business stop, tourism stop in a few months because everyone was scared. So, and you have negative growth.
I think a great example of making the economic argument and being effective is a demographic dividend,
Of course.
Which shows, it's an economic analysis, modeling, and then now empirical data that shows that if you improve the ability of women to improve their access of contraception, you then reduce the number of dependent people in the workforce because the women are able to work by spacing or limiting their children, and then you get incredible economic growth. That's been a very effective argument.
Yes.
And we need those kinds of data, I think, for other interventions as well.
Yes.
Yeah. So let me ask, is there anybody who'd like to participate in the discussion? Jimmy Lou, you want to? No? Okay, well, we'll keep talking. Okay. Here we go.
Thank you. My name is Simona. I am from Macedonia. Before coming here, I worked in a community-based organization of people living with HIV, and actually one of my first assignments was the national campaign Getting Down to Zero. So it's a real honor for me to hear from the person who was in charge of this vision. Macedonia has the support of the Global Fund for the last 15 years, but we are recently being classified as an upper middle income country. So that means that Global Fund cannot support the country anymore. So what would be your advice when we do advocacy in countries which are the support of the Global Fund is ceasing and the government is not seeing the importance of the community-based organizations and the work they do, especially when we take into consideration that it's a low prevalence country. And it has happened before in Croatia, in Bosnia, Serbia, Macedonia is the next one. So what would you advise us to do? Thank you.
We will take a series of questions, or I reply automatically? No, I think that is a very pertinent question. Is a serious issues in terms of how to deal with vulnerability. From my point of view, I am not talking so much anymore of fragile state. I'm talking about fragile community because I found them from Baltimore to Bamako. So how we find a mechanism with a clear criteria which will enable us to really make resource allocation available to those people who are disenfranchised, who are not capable to have access to, is a big issue. I saw that in Eastern Europe, Central Asia. Global Fund money was helping us to reach a gay population, to reach people who were injecting drugs. And then they stopped, but resource allocation was stopped at the same time from central level. So those people are not getting anymore any source of fund which will help to continue the program. And it was done with alternative service delivery, NGOs and others. And we are seeing today, epidemic is not controlled in those areas. Eastern Europe, Central Asia is the worst part for me. In the last 6 years, we have an increase of 60% of new infection amongst drug users who are hiding themselves, going underground because they are criminalized, because they are considered as criminals, so they are not rich with services. So we need seriously to think about that. And again, global health can be a good entry point to rethink this notion of reaching vulnerability. I saw that when I went to Atlanta, but I visited an hospital there. It was terrible. I saw people dying like in Lesotho a few years back. But of course, there are people without social capital. They are disenfranchised. They don't have access to treatment. They are reaching hospital very late with a CD4 very low. So what to do?
So we talked about this before, that America is a Puritan country. Right? We were founded by Puritans. And as children, those of you who grew up in the U.S. know, we used to have these cards and little cardboard cutouts of Puritans with the funny hats. And I didn't really understand what that meant until I left and came back and saw that in the U.S., many times unhealthy behaviors are seen as a moral failing, or low income is seen as a predestination, that this is God showing favor. So I understand that in this country, and it's an intractable part of our national thinking. But these other countries don't have that Puritan background. And what kind of interventions have been, besides the Global Fund and providing, how do you get leaders and communities to recognize that harm reduction strategies are in everybody's best interest?
I think you said something, Mike, which is very important. Data, evidence, and demonstrating that we have a return on investment. It took me a few years to really work with the Chinese government. It was zero tolerance for people who inject the drugs a few years back. But they are very pragmatic people, as you know. We managed to bring the evidence from Australia, from different places, to show that any dollar invested on harm reduction and other programs were bringing more return than they could think. And demonstrate demonstrate that putting people on a prison incarceration center because there is very expensive. When they are coming out, they are doing again. And they are coming back again, they are going back. And, so we try to think about different alternative approach. With that data, with evidence, with return on investment, and they have one of the biggest program on harm reduction in Asia today. It was zero tolerance. I said zero tolerance. They were considered as criminal, not acceptable. So I think we need to just make sure that we put also information, strategic information, which is not always reaching leaders in the right way.
Yeah. Other questions or comments back there, and then here?
Hi, thank you for this conversation. My name is Diane Caraggio. I'm with the Center for Public Health Advocacy, which is a new center at the school. And thank you to the Alumni Relations Group for putting this on. This is really fantastic. And so I'm curious, what role can advocacy play in helping you to reach your objectives, both on a global scale, but also on a national scale?
I think what UNAIDS has been able to demonstrate is that the missing link to all we have is advocacy, social mobilization. And that and communication combined together different pieces. And advocacy is helping us completely to change the decision of a policymaker by producing strategic information, using that strategic information as a means for global advocacy. And this global advocacy, when it's linked to a clear goals, is bringing solidarity at different level, and is changing completely the way to deliver services, and it creates pressure on actors to really fast track, to demonstrate that they can really reach their goals. So for me, that is a critical piece. Like I said, in the missing link in this whole agenda today of global health is what you're talking about, is a global health advocacy and accountability. I said accountability, because advocacy without accountability will not work very well, because you don't create pressure for return on investment.
Great. So here, please.
Ana Del Prado, a guest of Ruben Del Prado. And my question is, how can you deal when on the government or the country's side, it is a matter of punitive rather than financial reasons for the way they treat health problems or poverty problems?
I think it's a very difficult issue. That's why we try to really bring human right to health, and making sure that we are not silent. We are documenting, we are showing data, for example, gay people, sex worker, drug user, migrant, prisoner. If you go to that, they need services like anyone else. Migrant population, we cannot exclude any of those groups. But we are faced sometimes with a big problem. When you're in Venezuela today, to be very honest, people, we have been struggling, we have been fighting to make sure that they can have access to treatment. All the network of treatment are faced by breakdown. They don't have access to medicine, they don't. So the things you can do is to fight back, to make a noise, and to demonstrate that you cannot accept status quo for those people, because they don't have voice inside.
Erica, there's some people back there.
Right here, she has a question. Hello, my name is Warogoro from Kenya. I'm here doing my
When
MPH.
you say Morogoro, I realize that it's from Kenya.
I'm a medical student. I'm a physician here doing my MPH. My question is about global health and moving from programmatic to more systematic. If you look at Liberia and Sierra Leone and that region as an example, prior to the Ebola epidemic, millions of dollars had been pumped in, but in terms of very siloed programs. And so when something outside those programs hit them, the system was unable to withstand it. Do you think global health has learned from that? And do you think it has moved from programmatic to more systematic things?
I think system building is critical. Without any doubt, we know that one of the limitations we have today is our weak system. Like I said, when you have one doctor for 40,000 people, one doctor in Liberia for 90,000 people, and others, I can go on and go on, is not possible. We need to really think about how we build a system, how we transfer. But at the same time, I was advocating very strongly this year to convince the political leaders of Africa to adopt a 2 million community health workers. Because I am convinced that we can create jobs for young people, we can train them in, we need to create a proper, it should be a subsystem of health. It should not be the traditional community health worker, benevolent without, no, it should be part of the system delivery, subsystem of health with a clear supervision, with salaries which can help them to be part of the health system. And that can bring us to close to communities. Because for me, the biggest problem is the interface between last provider of health and community. And I said to my colleagues that I am very supportive of health system, but what we need now is a system for health, is to make sure that we build competencies, we make people capable. Ebola started with only one case in Guinea-Conakry border, but the person were not competent, and started bringing all his family, starting, traditional approach in terms of, when you have to burial and others. So, and then started going. So we need to think about that one and investing on that. But the biggest problem from my point of view is the issues of governance. We need to make our leaders, African leaders, understanding that you will not have a healthy continent, and I said today, healthy planet without healthy people. So they need to have a governance system which invests on health. And that for me is very important. And health is not to wait when you have disease to deal with. Lifestyles, education, how you bring this, how we deal with a growing obesity, NCD's problem, which will cost us a lot. So all those problems are problems which are, we are facing that already with all the people with HIV. They are all, now we have 5.3 million people on treatment. We are over 50 years old, but we are seeing already they are faced with the same problem, sugar disease, and others.
So let me, Erica, there's some people in the back who had their hands up. No?
Hi.
Hi.
I'm Melissa. I'm an attorney and an alumna of the Public Health School, and I represent sex workers and survivors of trafficking. And I'm so glad that you mentioned sex workers, and I know harm reduction has already come up in your talk, but I was interested to hear, I guess, what your thoughts are on how to sort of inform maybe the larger dialogue and political leaders around harm reduction, specifically with sex work and HIV and violence, and how criminalization really augments all of the problems that people in the sex industry face. So I would love any of your thoughts or tips.
I am fully with you. When I took this position, it was very difficult for me, because when I was looking again on data, I was seeing a growing epidemic amongst those groups. We have multiple epidemics on HIV today. We don't have one epidemic. When I really spent time to understand, I realized that it's the same people who are excluded from different. It's not just AIDS. You will find that they have this problem, they have this problem, they have this problem. So, and when I look at what was the reason, in many countries, it was due to bad laws. So again, health and how we deal with people who are talking about legislation, is very important. You cannot disconnect because, we try to fight. We try to make sure that we put a documentation out. I was in I was very surprised. I think it was Los Angeles, and I went there and I met a sex worker. I visited, and when I came out, and they told me, oh, be careful if you have more than 3 condoms on you, you can be considered a sex worker, and it's illegal. I was naive because Los Angeles, I said, no, it's not impossible, But just to say that we just a few years back, we could not come in a very advanced country like US, very democratic, when you were HIV positive. I had to fight back for travel restriction in so many countries. We removed travel restriction in many. And when US removed, China removed, different countries. And so we were having more than 73 countries with travel restriction. People were obliged to hide their drugs and hide their status when they were coming in most advanced country like US,
So I know there's a question over here, but let me just ask people who might want to ask questions to get their hands up. And so Erica can give. So Erica down here, would you give a mic there? And please, back. Yeah, I know. So we want to make sure the next person has a microphone.
Okay, hi, my name is Tija. I'm a physician from Nigeria. I've been working in community level, that's secondary health care facility. So while you were speaking, I was expecting you to talk about stigmatization, which is what I faced for years while I was working as a physician, because it's not just about access to antiviral drugs. No. I have a case in point where I was really touched in 2009 was as an intern, I had a patient who had 4 wives. He had been taking his drugs, but had stopped taking the drugs, so he had to come for readmission. But he kept on warning us as health workers that we couldn't tell any of the wives why he keeps on coming to hospital. So since I started working as a doctor, the cases I see of HIV or HIV-TB co-infections are spouses that one of them is on drugs and the other is not on drugs, or a spouse who always travels to another state to get medications and doesn't actually take it from where he's resident. So I don't know how it is that you are working on stigmatization in such situations. And adding to that, I don't know how you are working with, because Nigeria has a very weak healthcare system. There's no form of contact tracing of the aspect of men having sex with men is a whole different topic. I don't know what your thoughts are.
Thank you, my son. But I want just to say that what you said is very important. That's why I push the notion of zero discrimination. And now what we are doing is to work with different, structure, institution like yours and others to make sure that we promote zero discrimination on health setting. Because we are seeing people, like you said, who have been excluded or hiding themselves because they are scared to come even to talk to the physician in the health setting. So this is a very, very serious issue. We need to push it. We need to really make sure that we are. But the other issues you're talking about is also a very complex issues. If I look at today, we didn't talk about so much, in epidemic, I'm seeing 3 types of major problem. One is, like I said, this whole group of excluded sex worker, drug user, but at the same time, I'm seeing adolescent girls and who are really, particularly in southern part of Africa, faced with a serious epidemic. And we have a difficulty, really, because we don't reach them. They're taken hostage by their status, and we are not necessarily using the appropriate approach as education We know that, for example, from studies in Botswana, that any additional year of schooling reduce the infection by 11% amongst girls. But we know also that if you give cash assistance of $20 only to keep young girls at school, you will reduce the infection by more than 36%. And you will reduce early pregnancy, you will reduce early marriage. Many of those different aspects are coming together, and we need to leverage them. But the third problem for me is this infection amongst stable couples. Is a very, 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 very serious problem. We're seeing countries sometimes, we now manage in Lesotho, it was serious, 60%, I can say that 40% of the new infection were occurring amongst stable couples. But 60% of them were, how you call it? Discordant. So you have a wife is positive and the husband is not, or the husband is and the wife is not. And that is a big challenge when you talk about prevention. And to add to your point, what I'm pushing now is prevention also, prevention, and 2 or 3 of your public health leaders will come on October to help me to try to define a little bit what means controlling epidemic. Not just saying to the world, you need to buy 20 billion condoms, you need to make so many circumcision, but it means what for me if I am in the village, if I have 100 people in my village, and when I can say that the infection levels I should not. So that brings us to different levels in terms of incidence and in terms of registration of new infection, changing completely our public health information on those issues.
Okay, great. So Zori, you'll be next, but let me just ask, is there anybody else who wants to get in line and ask a question?
I think someone here.
Yeah, okay, so 2 mics over there. So Zori? Okay.
Thank you. Zori Glazer, welcome, and thank you for filling in. Dean Klag.
I was ambushed by him.
Yeah. He thought he was getting a free lunch.
No free lunch. I realized that. But I have to come back.
Dean Klag reminded us of our Puritan heritage in this country. Of course, we haven't entirely lost it. There are many sections of this country and many individuals who have expressed displeasure with the teachings currently of AIDS education, AIDS prevention education, and thought unkindly of concepts like needle exchange and so on. But more importantly, I think from your perspective, that of restriction of funding for international support, and how badly is that affecting your achievement of your goals?
I personally feel that it will be very serious. If we have a drastic cut, we will have a rebound in this epidemic. We lost completely our gain. We'll see mortality going up, and we'll see resistance being a part of our game. And that will be worse, because this resistance, we saw it with tuberculosis and others. It will be worse than that one, because you have, don't forget, 19 million people, 19.5 million people on treatment today. You have 17 million people waiting for treatment. So if we have a drastic cut, it will be terrible, terrible, terrible. But I don't want to be too negative, because what I saw in this country is just impressive. The citizens of US are unique. The compassion which has been there, and push really to make these issues bipartisan. I met all the different players from Republican to Democrat, senator, congressman, and women and others. And I can tell you that these issues is bipartisan issues, and it is central to their heart. The budget setting is one of the most complex things I saw in my life in U.S. So you cannot just think that because that has been proposed, it will be translated into like that. So we are hoping that it will not be like that. Because it's the citizens of this country, what they did, without them, without the sense of urgency, we would have lost millions of lives, honestly.
Please.
Okay. Hi, thank you for the speech. I'm Zahra. I'm a physician from Iran, and I'm doing my MPH right now. So considering the WHO is financially dependent on donors, I'm curious how the transformation would realistically happen. Would it be something imposed from the donors, or it would be a transformation starting from within the organization itself? Thank you.
I think Mike said something I didn't reply, and you will feel that I was not trying to reply. Is first the role of foundation and organization are critical because they're bringing money, they're helping us to focus on result and to have a sense of accountability and have projects which can go to scale, but they cannot be the one who will set a vision for the world. To set the vision, you need a multilateralism. Multilateralism is the only space you don't want, where people can come together and discuss and agree and say, okay, let us go with that. If you decide as a foundation or anyone to set a vision, it will take nowhere. Countries will not buy in. You can have a feel-good project. I don't say you don't have that. You will have feel-good project which will make, but you cannot make the world getting together and agree, each country translating that into project program, and where you can come with your money to improve. So WHO reform, one of the biggest challenge will be how to move from a state-centric type of organization to more open organization. UNAIDS, we have been very lucky. We have is one of the unique organizations in United Nations where you have civil society in my board. You have a private sector, people really capable to push back on a decision taken by their member state. And that make the debate healthy and make the transformation possible. Because sometimes those movements are far ahead than a member state. And you're from Iran. So I visited your country, and I was very surprised and impressed by what you're doing in prison. In prison with people who inject drugs, methadone distribution, syringe exchange, and I was shocked. And I remember being very surprised, positively surprised with the type of program you have in prison.
Well, I think we have to end now, unfortunately. I have to say that, after spending the day with you, I feel much better about the future of the HIV epidemic.
Thank you very much, Mike. Thank you.
So please join me. Thank you.
Thank to all of you. And I want just to say also that Secretary General asked me to continue until 2020, and he's asking me also.
He's a good person.
Yeah, thank
Smart
you.
man.
And he's asking me also to take the coordination of whole health organizations, so HS6, WHO, UNAIDS, World Bank, UNFPA, and UN Women. So I will have to work closely with you to help me on that.
We'll do whatever we can. Thank you. So